When life is at stake and time is running short, when every second counts and every moment counts, choose the one that is strongly recommended as the first choice vasopressor. Norepinephrine, Levophed SF, restores blood pressure in certain acute hypotensive states. In life-saving situations, choose norepinephrine, Levophed SF.
Pfizer's commitment to manufacturing excellence extends beyond quality injectables to important innovations like our proprietary Activial technology used for Solumedrol and Solucortef. The easy-to-follow instructions are: press down on plastic activator to displace center stopper, forcing water for injection into lower chamber. Gently shake to effect solution. Bring product fully into solution before inserting the needle. Remove plastic tab at center of plastic activator to reveal stopper. Insert needle through center of stopper at a 90-degree angle until tip is just visible. Then, invert vial and withdraw required dose. Pfizer's unique Activial technology, providing physicians and patients with convenience and safety in drug delivery.
Before we formally open this event, we would like to put down some reminders. This presentation is being recorded. During the duration of this webinar, kindly turn off your camera and keep your microphones on mute. For questions and clarifications, please type your concerns in the chat box. Our moderator will go through the questions during the open forum. Also, please remember to fill out the evaluation forms before leaving the webinar. A link will be provided in the chat box later. In this breakout session, let us refamiliarize and update ourselves with the latest guidelines in the management of gout. This session is headed by Dr. Julie Liu. She is an associate professor at the University of Santo Tomas Faculty of Medicine and Surgery and is the current head of the Rheumatology Center at the University of Santo Tomas Hospital. She is also an ISCD certified bone densitometer reader. This session will be moderated by Dr. Katrina Paulino.
Good afternoon, everyone. First and foremost, I'd like to thank the organizer and congratulate them for this Tiger's first virtual postgraduate course with the topic Clinical Practice Updates in Internal Medicine. So the topic that's assigned to me is to talk about gouty arthritis this morning. Objectives set forth is to promote evidence-based medical practice by discussing presentation of crystal-associated inflammatory arthritis and sharing the latest clinical practice guidelines from global to local applicability on gouty arthritis. So let's start first with a case, a 45-year-old overseas contract worker who came in because of acute left ankle followed by right knee joint arthritis for the past 2 weeks. He admitted to have this arthritis partially relieved by intake of as necessary ibuprofen. The visual analog pain score has been fluctuating for the past few days. On physical examination, he walks into the clinic with a limp. He's obese, hypertensive, afebrile. The right knee joint was swollen, markedly swollen, tender, and worn, while the left ankle joint, though it's swollen and tender, markedly much reduced, okay, compared to the right knee joint, not warm at all, no evidence of tophi. Medications that he has been taking includes metformin, Aspilet, telmisartan with hydrochlorothiazide. So from these medications alone, we are able to decipher that this patient has diabetes as well as coronary artery disease and even hypertension. So the physical examination of his joint, so the right knee shows remarkable swelling, while the left ankle joint looks like it's a receding arthritis already. So what is then our clinical impression? What will be our basis? So as part of the history of the physical examination or physical history of a present illness, rather, we had to focus on the onset of the problem, onset of arthritis, when did it start, how did it start, where did it start, which connotes the location. Duration is how long has it been disturbing the patient, what's the characteristic pain that this patient is complaining of, if and when he will be able to qualify, what aggravating factors were there that triggered the onset of arthritis, what has he done in order to be relieved of the pain as well as the swelling, what treatment has he received, and how severe has the problem been for the past 2 weeks. For the medical history, we would want to get if and when your patient had previous episodes. So for this patient, he admitted to have episodic or recurrent monoarthritis that has been there for the past few years to a decade already. He also admitted, or on further probing, there's history of urolithiasis. Patient underwent shockwave lithotripsy already. He also had evidence of metabolic syndrome, though not certain on persistence of the history of hyperuricemia. His dietary consumption as well as personal social history, he has been taking more sweets, okay, than ordinarily, and has been an alcohol drinker. So based on this different data that was gathered from your patient, the clinical impression most likely will be a crystal-associated arthritis, likely to be gouty arthritis, given the profile of our patient that he's 45 years old, he's obese, he might have, okay, hyperuricemia, though not documented, but presence already of urolithiasis as well as recurrent or episodic monoarthritis in the past speaks high likelihood that this patient has a gouty arthritis. So what then should we also be considering? Now, in the presence, if and when there's doubt, what should we do? One important differential diagnosis that one should not miss out on will be on septic arthritis, which is considered a rheumatologic emergency. So what factors should we consider in the patient for one to think of septic arthritis? Risk factors should include an immunocompromised state. So this patient has been diabetic, though we are not sure if and when this is controlled, if the patient has been adherent to oral hypoglycemic agents, presence of trauma. Are there any recent genitourinary or gastrointestinal tract infection that will make one think of reactive arthritis? Use of steroids. A lot of our patients with gouty arthritis has been using and abusing corticosteroids. So for definitive diagnosis, with the luxury that we have, if and when your patient, just like our patient, having a markedly effused knee, there should be the benefit of doing an arthrocentesis. Arthrocentesis can both be diagnostic as well as therapeutic. For diagnostic, we should be able to get synovial fluid aspirate or examination confirming the presence of gouty arthritis. So we try to identify crystals under polarizing microscope and even send synovial fluid for WBC diff count, and if necessary for cultures if and when we're thinking of septic arthritis. Other diagnostics should also include blood examination like your CBC, look for leukocytosis, elevated acute phase reactants, need to do some blood cultures, okay? And of course, in the presence of diabetes, ensure that our patient has a good control of his diabetes. For blood uric acid level, will this be the best time to get blood uric acid level? So we know during acute stress, you have secretion of your ACTH. So ACTH is considered uricosuric. Therefore, getting blood uric acid during acute stress, during acute arthritis, might not be helpful because most of these patients might be normouricemic. Other than that, secretion of pro-inflammatory cytokines during acute arthritis is also considered uricosuric. Renal function tests should also be requested in order to ensure that our patient does not have any evidence of chronic kidney disease on the background of taking NSAIDs in the past during recurrent or episodic monoarthritis. So based on the 2018 EULAR or European League Against Rheumatism evidence-based recommendations for the diagnosis of gout, what did this recommendation tell us? So recommendations for the diagnosis of gout, identifying MSU crystals is still the definitive diagnosis for gouty arthritis. If and when you don't have the luxury of getting synovial fluid, we can still make a clinical diagnosis of gout depending on the following features. Presence of monoarthritis of the foot, maybe the first MTP or your podagra, or even the ankle involvement. Previous similar acute episodes, it can be a few years ago, it can be decades ago. Rapid onset of arthritis, less than 24 hours at its worst. So that's the time that the full-blown arthritis sets in. Presence of erythema, if and when your patient is male, alcoholic, presence of comorbidities like your CVDs and even hyperuricemia. All of these factors can lead to a clinical diagnosis of gouty arthritis. So if and when it's uncertain what's causing the inflammatory arthritis, it's strongly recommended that one should do arthrocentesis. Diagnosis, always remember, diagnosis for gouty arthritis is not dependent on hyperuricemia alone. How about the role of imaging? Imaging in order to search for MSU crystals or even features of alternative diagnosis should be considered. So imaging like plain radiograph, though it's non-specific during acute synovitis or acute arthritis, most especially during the early years of gout, plain radiograph might not be that helpful. Ultrasound, on the other hand, is helpful if and when tophi are not evident on physical examination. What do we look for in ultrasound? We look for double contour sign, wherein deposits of your MSU along the hyaline cartilage surface. Risk factors for chronic hyperuricemia should also be considered. Presence of CKD, overweight, use of drugs like diuretics, low-dose aspirin, cyclosporine, even your tacrolimus, excessive alcohol consumption, excessive consumption of non-dietary sodas, meat, and even shellfish. So these are considered risk factors for possible, contributory risk factors for possible gout. And of course, systematic assessment of comorbidities should also be done once you are working up a patient for gouty arthritis. This graph is recommended diagnostic modalities according to the disease states of gout. So you can have preclinical states wherein patients have asymptomatic hyperuricemia or even asymptomatic MSU crystal deposition using your ultrasound. And then moving on to gout as the clinical states. So you can have gout flare, your intercritical gout, or even your chronic gouty arthritis or chronic tophaceous gout. So the EULAR therefore recommends three-step approach for the diagnosis of gout. First step is to search for MSU crystals. So be it doing arthrocentesis or do arthrocentesis if and when there's already evidence of synovitis or even positive bulge sign. you can search for MSU crystals. Or in the absence of synovitis, even doing the ultrasound can already give you a lot of information. Presence of double contour sign might possibly be a clinch to the diagnosis of asymptomatic gouty arthritis or asymptomatic MSU crystal deposits. Step 2 will be basing on your clinical diagnosis. So for your clinical diagnosis, you need the presence of hyperuricemia as well as certain clinical features that's compatible with gouty arthritis. And then step 3 will be your imaging. So it is recommended to do imaging if and when, okay, there's no evidence of tophi formation, of course. There's you would want to elicit or confirm, okay, the diagnosis may be that this patient might have a double contour sign. You can use imaging like your ultrasound, okay, when the clinical diagnosis of gout is uncertain. And then, of course, on the right clinical states of gout flares, intercritical gout, or even your chronic gouty arthritis, okay, you can still search for MSU crystals. But of course, during the chronic tophaceous gout, there's already the evidence of tophi that you need not confirm, but yet just make sure that your patient does not have septic arthritis on top of a chronic tophaceous gout that will warrant aspiration or arthrocentesis. So will imaging studies be helpful? So as mentioned, okay, we can use radiograph, you can use ultrasound, and you can even use dual energy CT scan. So for this patient who already had numerous subcutaneous tophi on top of a chronic tophaceous gout, for purpose of academic reasons, okay, you can still do imaging studies like your radiograph, wherein the prototype or pathognomonic features of chronic tophaceous gout is overhanging edges or overhanging erosions, wherein it is usually described in textbook as rat-eaten edges of the bones. So in these kinds of patients, that means your patient has been long standing chronic gouty arthritis patient without being seen or without even being adherent to therapy. Another will be your ultrasound, as mentioned. On the left upper hand corner will be your double contour sign. So you'll see this opacity, okay, wherein it means that MSU crystals have deposited on the surfaces of the hyaline cartilage. What other advantages of ultrasound is to be able to document or identify or even measure the dimension of tophi. So you can have intra-articular tophus formation that's seen on ultrasound and even measurement of the dimension. And then on the upper right-hand corner will be presence of erosions that also are seen on ultrasound. Another imaging modality that might be useful is what you call your dual energy CT, wherein sometimes some of the tophi might not be palpable clinically. Henceforth, you would want to document the presence of tophi that might be hidden in some parts of the body or in some parts of the bone or soft tissues. You can use your dual energy CT scan with a high specificity as well as sensitivity. However, the radiation dose is much, much higher whenever you subject a patient to dual energy CT scan. So how then will we treat this patient? So we have such a thing as we call them short-term goal and long-term goal. For the short-term goal is actually to just treat the acute arthritis. For the long-term goal, we need to control the recurrent flares of gout by treating to target level in order to control the recurrent flares of gout. So as mentioned a while ago, we have clinical phases of gouty arthritis. So our treatment will really depend on which clinical phase of gout this patient, our patient, has. So you can have asymptomatic hyperuricemia. What evidence are there in order to address asymptomatic hyperuricemia, acute gouty arthritis, intercritical gout, or even chronic tophaceous gout? So the 2020 American College of Rheumatology guideline for the management of gout states what are the different evidences. For gout flare management, We have the level of recommendation as well as the grade of evidence. So what are the different agents that we do use for gout flare management? So oral colchicine, NSAIDs, or glucocorticoids are considered first-line therapy for patients with acute gout. However, choice of agent will certainly be dependent on patient's factors. So for those with uncontrolled diabetes, who are in sepsis, of course, our choice will not be glucocorticoids. So for giving colchicine, it has to be a low dose colchicine over high dose colchicine. So low dose colchicine means we load 2 tablets of colchicine. In the States, the preparation is 0.6 milligrams. Locally, it's 0.5 milligrams. So we can give 1 milligram or 2 tablets of colchicine, followed by 1 tablet an hour later for patients with acute flare of gout, and then maintain them on twice a day. Over high dose colchicine, wherein in the past, patients were given hourly doses of colchicine until diarrhea sets in. It is not recommended anymore because other than GI toxicity, cardiotoxicity can also set in. So if a patient is kept on MPO, then we can use systemic glucocorticoid in order to address acute flare of gout. Now, for certain instances wherein oral colchicine, NSAIDs, or glucocorticoids are contraindicated, other specialists, will give anti-IL-1 antagonist or your anakinra. Sad to say, we don't have it available locally, but it's an option that one can consider. So topical ice, it's conditionally recommended, though with low grade of evidence. The topical ice can be given to patients with acute flare of gout. Over 1 compress, of course. So when should we start pharmacologic urate-lowering therapy? So the urate-lowering therapy may be in the form of allopurinol, your febuxostat, or even your probenecid. So for those with at least 1 subcutaneous tophi, frequent flares of more than twice a year, and radiographic damage consistent with gouty arthritis, it is strongly recommended to start these patients already on urate-lowering therapy. If and when a patient has more than 1 flare but have infrequent flares of less than twice a year, it's conditionally recommended to start them on urate-lowering therapy. If and when there's only 1 flare and never had flares at all, it's conditionally recommended against giving urate-lowering therapy to these patients. However, if a patient has the first flare on top of a CKD of at least stage 3, hyperuricemia of more than 9 milligrams per deciliter, or already presence of urolithiasis, it's conditionally recommended to start these patients on urate-lowering therapy. And for asymptomatic hyperuricemia, this is the only recommendation that ACR came up with. For asymptomatic hyperuricemia, uric acid level of more than 6.8 milligrams per deciliter with no prior gout flares, no subcutaneous tophi, never had any acute arthritis, it's conditionally recommended against starting these patients on urate-lowering therapy. Try to address or try to look for other comorbidities that could have contributed to hyperuricemic state of these patients. What choice of initial urate-lowering therapy should be given to the patient? So we can initiate allopurinol, which is considered the first xanthine oxidase inhibitor as a choice, even among patients with CKD stage 3. Start low and go slow. So don't just be satisfied with just keeping your patient on fixed dose of your urate-lowering therapy. However, if and when you're just starting this patient, you can start them slow and go slow in up-titrating the dose. So you can start allopurinol, at least 100 milligrams per day, or even febuxostat, 40 or even lower than 40 milligrams per day. Anti-inflammatory prophylaxis in the form of colchicine should be given as well. Though in the US, prednisone has been recommended as an anti-inflammatory prophylaxis locally. That's why I highlighted this in red. Locally, we don't advocate giving prednisone as an anti-inflammatory prophylactic agent because a lot of times we do get patients who already have been abusing corticosteroid and coming in already with adrenal insufficiency and Cushingoid features. Therefore, anti-inflammatory prophylaxis should consider patients' risk factors as well. Prophylaxis should be given at least 3 to 6 months or even continue on if flare continues in patients despite adherence to therapy. If urate-lowering therapy is needed during flare, one may start, however, still need to consider certain patient factors. 2 small RCTs and an observational study has shown starting patients during acute flare on low-dose urate-lowering therapy did not lengthen the duration of acute flare. However, this needs larger clinical trials or larger population RCTs. Recommendations for all patients taking urate-lowering therapy. There's such a thing as we call the treat to target. Just like treat to target for your hypertension, for your diabetes, in rheumatology for gouty arthritis, there's what you call your treat to target level of less than 6 milligrams per deciliter. So in order for us to reach the treat to target level, dose titration should be done guided by serial serum uric acid level. So do not get your uric acid level during flares of gout because, as I have said a while ago, most of these patients during acute flare of gout are normouricemics. Get their serial uric acid level during the intercritical period. That will better reflect the true uric acid level of your patients. In the States as well, augmented protocol of urate-lowering therapy dose means these are mostly nurse-led or even pharmacist-led, educating patients on how to manage gouty arthritis. Again, treat to target level should be less than 6 milligrams per deciliter. And should we continue urate-lowering therapy indefinitely, it is hereby recommended that we need to continue these patients on urate-lowering therapy indefinitely, though it's conditionally recommended. There are some observational studies wherein there's one observational study wherein only 20% of patients who have their uric acid level kept at less than 7 milligrams per deciliter, never been or had their urate-lowering therapy withheld. Only 20% of these patients did not ever have gout flares after 5 years of follow-up. So a big chunk, or the 80% of patients in that observational studies have flares of gout once their urate-lowering therapy were withheld. Management of lifestyle factors. It's conditionally recommended to limit alcohol, purine intake, and even the high fructose corn syrup, as well as addressing overweight and obese patients with gout. And for the management of lifestyle, it's conditionally recommended against giving these patients vitamin D supplementation. And lastly, managing concurrent medications, conditionally recommended to switch hydrochlorothiazide to alternate antihypertensive. Conditionally recommended that losartan should be used as the antihypertensive agent, and then conditionally recommend against stopping low-dose aspirin. So giving patients on low-dose aspirin will benefit their coronary artery disease, so it's not recommended that we stop low-dose aspirin if and when there's an indication to do so. Conditionally recommended against adding or switching to fenofibrates for patients with dyslipidemia. So among the different antihypertensives, it's losartan and calcium channel blockers are considered mild uricosuric drugs. So for patients who have hyperuricemia, hypertensive, dyslipidemic, sometimes in the clinics, we can choose some of the drugs with mild uricosuric drugs or agents, properties, okay, that can complement the urate-lowering therapy that we give these patients with hypertension and dyslipidemia. So the key points that I'd like to drive after this lecture is to tell everyone that gout is still very prevalent among Filipinos. We need to know what to ask in order to clinch the diagnosis of gout. And remember, hyperuricemia is not always equal to gout, but certainly gout patients are almost always hyperuricemic. Therefore, having said that, there's no evidence that treating asymptomatic hyperuricemia with urate-lowering therapy significantly reduces the risk for CKD, CVD, or even overall mortality. We still need larger randomized control trial in order to address and answer the issue of lowering uric acid level with the outcome of CKD, CVD, and overall mortality. Know the phases of gout in order to successfully treat your patient. Which phase of gout you are treating in order not to be frustrated in treating gout patients. Remember as well that gout and septic arthritis can coexist. Therefore, we need to treat these two conditions concurrently. Treat to target level, remember, is a uric acid level of less than 6 milligrams per deciliter, and this can only be achieved by your urate-lowering therapy, not with colchicine. For patients with chronic tophaceous gout, we need to reach lower serum uric acid level, maybe lower than 5 milligrams per deciliter. And in terms of lifestyle risk factors, we can encourage our patient to for a moderate consumption of everything. Not all patients are alike. So if and when your patient admittedly will have flare of gout after consuming certain diet or dish, so we try to discourage this patient to continue on with that kind of a diet, but not similar diet to all patients with gouty arthritis. So with that, I'd like to thank you for listening.
In this next lecture, let us remind ourselves of the importance of rational use of antibiotics, especially in this time of pandemic. This session will be given by Dr. Jade Javier, a graduate of the University of Santo Tomas Hospital Medicine and Infectious Diseases Fellowship Training Program. She currently heads the Anti-Microbial Stewardship Committees and Infection Prevention and Control Committees of Batangas Medical Center and other private hospitals in Batangas. This session will be moderated by Dr. Katrina Paulino.
Okay. Good morning, everybody. Thank you for inviting me to the first virtual postgraduate course of Tiger. So I am Dr. Jade Javier. I'm an infectious disease physician from Batangas, and I'm a graduate of USTIM. I was tasked to give a short lecture on antimicrobial stewardship, but I would like to make it more relevant and interesting. So I relate it to the current pandemic situation that we are in. Antimicrobial stewardship, unfortunately, has been something buried underneath the information overload of COVID-19. I think we are all relating to this. And it's actually a breather for me to be giving a lecture on antimicrobial stewardship and not COVID-19. And so for the objectives of today's lecture, I would want it to be simple. First, for us to be reminded of the importance of key concepts of antimicrobial stewardship, or AMS, as we commonly call it. And second, to relate these principles in the midst of a viral pandemic. All right, so let's start. First, let's define stewardship. Now, according to our reliable Wikipedia, stewardship is an ethic that embodies the responsible planning and management of resources. And this is related also to how Merriam-Webster Dictionary defined it. It's the careful and responsible management of something entrusted to one's care. So as clinicians, as doctors, I think we are all stewards in terms of the responsibilities that are given to us. And this also includes rational antibiotic prescribing. So according to CDC, antimicrobial stewardship is an effort to measure and improve how antibiotics are prescribed by clinicians and also how they are used by patients. So it's an effort between the doctors and the patients themselves. its main goal is to effectively treat infections, to protect patient from harms, not only harms of the body in terms of adverse effects, but also in terms of costs, right? Especially in irrational antibiotic use. And also, one of its main important goals will be, well, equally as important, would be to combat antibiotic resistance. So antimicrobial resistance is a growing threat. And actually, this is an understatement because it's not only a growing threat, it's a big, big threat already for decades. And it's actually still growing every year as we prescribe antibiotics. And here I'd like to present to you this very familiar slides. And this is the CDC threat levels of the superbugs. Here in the slide, they divided it into 3 categories: urgent hazard, serious hazard, and concerning hazard levels. Among the urgent hazard levels, it would include Clostridium difficile infections, carbapenem-resistant Enterobacteriaceae infections, and also cephalosporin-resistant Neisseria gonorrhoeae. Among the serious hazard levels, these include multidrug-resistant Acinetobacter, multidrug-resistant Pseudomonal infections, extended-spectrum beta-lactamase, Enterobacteriaceae, and methicillin-resistant Staphylococcus aureus, to name a few of these serious hazard level superbugs. And concerning hazard levels will include VRSA, macrolide, and clindamycin-resistant streptococci. So if you might notice, a lot of these organisms are very common already in our local setting, especially the MDR Acinetobacter, ESBL, gram-negatives, and MRSA. Unfortunately, this slide came out 2013. So it's very familiar already because we've been using it for the past years in terms of lectures, in terms of patient and doctor education. However, if we visit the latest list of superbugs, you would see that the list has grown significantly. And now, carbapenem-resistant Acinetobacter has been pushed to an urgent threat already to include carbapenem-resistant Enterobacteriaceae, Clostridioides difficile, and so on. Serious threats already also have grown, as well as the concerning threats. However, in the 2019 list, there is a new column wherein we have a watch list for new emerging drug-resistant organisms, and not only in terms of bacterial infections, but also fungal infections. So this is the CDC list. And if I may share experience as an infectious disease doctor, a lot of these organisms are already present in our local setting. Now let's visit what we have in the Philippines. And I went to the ARSP document. So it's Antimicrobial Resistance Surveillance Program from DOH. And I like to give you some examples of drug-resistant organisms that we have in the country. First in the list will be Staphylococcus aureus. So it's a common organism that causes skin and soft tissue infections, catheter-related bloodstream infections, and pneumonia. And if you would notice, look deeper into the slide, you would see that the MRSA rates in the Philippines is very high and actually alarming, to as high as 54% last 2018. Now, MRSA infections will prove to be more difficult to treat infections and more severe infections. The drug of choice will be vancomycin, of course, among the other MRSA active antibiotics. And this would mean that these strains of Staphylococcus aureus are already multidrug resistant. If we would focus on the different sentinel sites that have been taken by ARSP, you would see that in some institutions, some sentinel sites, MRSA rates will go as high as 80%, 76.5%, but roughly at an average of 50%. Now, practically, that would mean that half of our isolates are already MRSA. And this is very important for us to know, for us to be guided on our empiric treatment for our patients. Now, that's for the gram-positive organism. What about gram-negative organisms? So we have a common example would be Klebsiella pneumoniae. And if you would notice, what's interesting here is that the drug resistance against ceftriaxone, cefuroxime, cefepime, ciprofloxacin, drugs that we commonly use on a day-to-day basis, will already have resistance rates of 20 to around 50%. And this is very important because the drugs that we commonly use may not be working at all if we get these types of Klebsiella pneumoniae strains, the multi-drug resistant strains. Now, in terms of ESBL positive Klebsiella or the extended spectrum beta-lactamase producing Klebsiella, we also would see that the resistance, the presence of ESBL is also significant and very high among the sentinel sites. And these sentinel sites are representative of basically what we have in the Philippines. It can go as high as to all of the isolates were already ESBL positive. And ESBL, for the knowledge of many, is gives multi-drug resistance to gram-negative organisms, and the drug of choice will already be carbapenems. Speaking of carbapenems, the last example would be Acinetobacter baumannii infections, wherein the behavior of this organism will be to develop drug resistance fast, including carbapenems. And if you would notice, in the past decade or so, carbapenem resistance has been increasing steadily. And so we would need higher classes of antibiotics, if not stronger classes of antibiotics in the form of polymyxin and in combination with carbapenems. Now that is for a different discussion. Now the point here is that carbapenem resistance is present already in our gram-negative isolates. Okay, the main driver or the most important driver, I think, of this drug resistance will be inappropriate and irrational use of antibiotics. And this is where us as stewards, our roles come in. So AMS is very important. That's why all hospitals in the Philippines must have an AMS program. And this has been mandated already by DOH. I remember before the pandemic came in, AMS was the hype. We were all busy in terms of infectious diseases. Most IDS clinicians were very busy in putting up the AMS programs in the hospitals as early as 2017, 18, and 19. Okay. So what is the AMS program? Well, actually, the AMS program is a concerted implementation of systematic, multidisciplinary, multi-pronged interventions in both the public and private hospitals. It's a collaboration between all the units in the hospitals to include the administration, the doctors, the nurses, the pharmacy, the laboratory, and all the other stakeholders, including the patients and their relatives. And the main goal of AMS will be to improve appropriate use of antimicrobials, not only antibiotics, but also antifungals, and now in our scenario also, probably antivirals also. So why do we need AMS? What is its goal? Well, the goals of the AMS program are as follows. First will be to improve patient outcomes, and that's in terms of reduction of morbidity and mortality. Next would be to optimize the selection, the dosing, and the duration of antimicrobial therapy in individual patients. So am I giving the right antibiotic? Am I giving the right dose? And along with this, one of its goals also would be to reduce adverse reactions like Clostridium difficile infection, hypersensitivity, and also acute kidney injuries. It also would long to reduce the length of hospitalization and consequently the costs of hospitalization. Lower hospital bills, lesser antibiotics to buy, lesser medications. And as I've mentioned, it wants to slow down the emergence of antimicrobial resistance, not only in the country, but globally. And us as doctors, of course, what do you think is the most important goal? Well, the most important goal of AMS would, of course, to improve our patients' outcomes, our patient care. All right, so these are the core elements of the AMS program. I'll go through with them briefly with you. So the first, it starts in terms of leadership. So the first core element will be leadership. There should be somebody or a team steering the hospital to have an AMS program. And I think by this time, most of our hospitals, if not all, already have an AMS team or an AMS committee in place. Probably most especially in the secondary and in the tertiary hospitals, most of us will be familiar already with this. Second core element We have policies, guidelines, and pathways to follow. A lot of guidelines and pathways are available already, including our national antibiotic guidelines and specific subspecialty and specialty guidelines that we can follow in terms of antibiotic prescription. It also includes surveillance of antimicrobial use and antimicrobial resistance, and this will be the main drivers here will be our pharmacy, our laboratory, including the infectious disease team. Core element number 4 will be the actions, and I'll share some things with you in a few slides about this action. Core element number 5 will be education, not only of the doctors, but also the patients, the nurses. Everybody should be educated on why and how the AMS program should go in the hospital. And lastly, will be performance evaluation. For every action, there should be evaluation. Are we meeting our goals? Are we meeting our goals on time? So this is basically the AMS program. It's more tedious than this if you go through the entire process, but it is important for us to know that our hospitals should have this type of committee or team. Okay, so for us to make it more relatable as doctors, I would like to share with you some questions that AMS would like to answer on a day-to-day basis. So Anti-Microbial Stewardship or the AMS team would want to guide us. First question is, am I giving the right antibiotics? Am I following the guidelines? Is my prescription correct? Is it according to the pathways that were given to me? Is my antibiotic dose correct? Is my creatinine clearance computed for? Do I have to adjust according to the liver function of my patient? Another question would be, am I giving my antibiotics for too long? Should I give it for 5 days? Should I give it for 14 days? I know this is a question the AMS team in your hospital would be very happy to answer. And all of these will be according to the guidelines that we're following. And lastly, does my patient need any antibiotic at all? A relatable situations here would be if your patient is being treated for a non-infectious cause, is your patient for surgery and requiring only prophylactic antibiotics, or does your patient have a viral infection, not only COVID, but dengue infection, the flu? So does my patient need any antibiotic at all? Well, the AMS can help us to answer these questions. Okay, some doctors have been quite resistant at first, or probably consistently resistant, and they might think that AMS is stopping them from giving the antibiotics that they want. I want to give meropenem to my patient for a moderate risk pneumonia without any antibiotic history. So they're being stopped by AMS. That's how they feel. But actually, AMS is here to give you the antibiotics that you need. And this is according to the guidelines and also to the assessment of the patients that we both are treating. Okay, so here, again, core element number 4, it would be action. And these are, I think, most of us can relate already with this. The first action will be restriction and pre-authorization. And this is when we are to prescribe antibiotics, restricted antibiotics, for example, carbapenems, vancomycin, linezolid, tigecycline, and these are antibiotics that are being preserved. And so when we prescribe these antibiotics, we would want to have pre-authorization. So when you prescribe it, the AMS will be tapped and they will approve, disapprove, or suggest something else. Now, in the COVID pandemic, I hear of some hospitals including remdesivir to the restriction and pre-authorization arm because apparently there have been some doctors who have been prescribing remdesivir left and right for, questionable indications. So these actions are modifiable according to the hospitals that you are working in. So it's not a stringent set of list, okay, a list of any antimicrobials, but we can add or remove any infectives as we deem it. Okay, so the next will be 7th-day automatic stop order. This will include all of the antibiotics, whether oral, restricted, or not. And unless the doctor has indications to extend antibiotics, like for example, severe infections, sepsis, bacteremia, all of the antibiotics will be automatically stopped, of course, with the prompting of the prescriber. Point of care interventions will be on a more day-to-day basis, wherein we can guide you, the AMS can guide you in terms of dosing, indication for treatment. And this is somehow related to audit and feedback, wherein patients receiving antibiotics already, their clinicians are called in to review the antibiotic use. Can we stop it already? Should we escalate? Should we de-escalate? And so on. So as you might notice, as you might realize, the AMS has these goals not only for the doctors, but mostly for patient care. Now, for the second part of this lecture, I would like to relate AMS in the COVID-19 pandemic. And in a nutshell, basically what I'm trying to say here is that during the pandemic, the goals of antimicrobial stewardship remain unchanged. The goals that I've presented to you, they still are the same. And our lecture here is for us to know the importance in terms of antibiotic use in COVID. So in terms of patient care, decreasing the costs, and combating antimicrobial resistance, these would all be the same in the COVID-19 pandemic. Now, one interesting fact, during the COVID-19 outbreak, antibiotic use has actually increased, especially respiratory antibiotics. Now, that's quite interesting because we have a viral pandemic, but the antibiotic use has increased. And according to the Singapore data, you would notice that during the early months of the pandemic, January up to at least March, there has been an increase, a spike in antibiotic use in COVID-19. And here you would see February, March, April, roughly around January, February, and March, there has been around 25 increase in antibiotic use for the treatment of community-acquired pneumonia. Now, as the knowledge in COVID-19 infection increased, you would notice that antibiotic use has been steadily decreasing. Here, I'd like to share with you Korean data, okay, in terms of the usage of antibiotics in COVID-19 patients. So in this study, they had around 6,800 patients, and they found that 35% of these confirmed COVID-19 cases were being given antibiotics. And around 8% of those antibiotics were targeted against MRSA and pseudomonal infections. 86% of those 6,800 patients had mild to moderate illness, while 13.7% had severe to critical disease. And among the mild to moderate illness patients, around a third or 30% have been given antibiotics for the treatment of COVID, compared to severe to critical illness patients, wherein 80% were prescribed antibiotics already. So you would see in this paper that around 42.95% of those patients with severe to critical COVID were actually prescribed anti-MRSA or anti-pseudomonal antibiotics. And that is actually significant. That's significant, but not surprising, because we might also be able to relate in terms of our local settings. So the sad truth is, in the pandemic, adherence to established antibiotic stewardship programs has declined significantly, as us providers, the doctors, struggled to save the lives of patients with COVID-19. And in the lack of any treatment options, especially in the beginning of the pandemic, naturally, antibiotic use would be one of the most common choices. All right, so the question here is antibiotic use in these patients justified? Meaning, do they really have bacterial infections? So I tried to look into the literature. How common is it for COVID-19 patients for them to get bacterial infections. And here I stumbled a few papers on it. And one paper said that less than 8% of patients with COVID-19 actually have respiratory bacterial co-infections. So that's quite low. And according to meta-analysis, they found that only 3.5% of all COVID-19 patients from mild to critical illness actually presented with a co-infection. Co-infections with bacterial infections, with bacterial organisms, specifically Mycoplasma pneumoniae, Haemophilus influenzae, and Streptococcus pneumoniae. So actually, if you come to think of it, out of 100 patients, only 3 will have bacterial co-infections. Now, how about in the critically ill? They found that only an estimated 8% developed bacterial infections, whether it be co-infection or secondary infection. So here, this is actually from the meta-analysis that I have mentioned to you a while ago. And what I'd like to emphasize here is that despite having only 3.5% of co-infection on presentation and 14.3% secondary infection after presentation, there has been a high 71.8 antibiotic prescribing attitude of the clinicians. Okay, so you might see that actually it's not that common for COVID patients to have bacterial infections. And this will also answer our question a while ago in terms of antibiotic use. So therefore, the US NIH does not recommend antibiotic prescription for patients with COVID-19 unless, of course, there is a clinical suspicion of a bacterial infection. Okay, so how do we decide? Does my patient need antibiotics or not? So I tried to look for literature on how to guide us in terms of starting antibiotics. And I stumbled upon this article, I think this is from Belgium, wherein they gave us a good algorithm, a simple algorithm on when and when not to start antibiotics. So in your COVID-19 patient, this is in ICU patients, so meaning they might be the severe or critical diseases. If one of these factors are present, septic shock or a focal infiltrate compatible with bacterial pneumonia on CT scan, if CT scan is not available, especially in our setting, probably a chest x-ray, then if any of these factors are present, then initiation of antibiotic therapy is warranted. And of course, microbiological sampling would be ideal, although challenging. I'll show you later on. And once we start antibiotic therapy, or even before starting antibiotic therapy, we would want to use or consult our local guidelines in terms of treatment for community-acquired or hospital-acquired pneumonia. Once started antibiotics, we would want to give them for the shortest period of time possible, possibly 5 to 7 days, and consider de-escalation of our antimicrobials early. Now, if septic shock or bacterial pneumonia on imaging is not present, then watchful waiting, close observation of your patients may actually be enough. And treatment for COVID infections may actually be enough. And of course, we won't be discussing how COVID is treated, but antibiotics is certainly not first line in these patients. Microbiological sampling, again, would be ideal, of course, along with rapid diagnostics. And here, something that we can use in our setting would be serial procalcitonin monitoring. And as you might know already, higher procalcitonins will support bacterial infection in our patients. All right. So I've been mentioning about the challenges on microbiological sampling. Well, actually, because in our setting, and I can relate to this, we would somehow tend to avoid diagnostic procedures. And some procedures like, for example, suctioning or manipulation of the oral mucosa, sputum collection, and also our attempts to minimize healthcare worker exposure, these would somehow make it difficult for us to diagnose bacterial superinfections in COVID-19. And I'm sure many of us can relate to this. But again, according to the past slide, microbiological sampling would be ideal in our patients. Okay, so next question, did COVID-19 exacerbate the superbug threat? In terms of the increase in antibiotic use, even though we are treating viral infections, did it exacerbate our superbugs or our multi-drug resistant organisms? Well, actually, the answer would be probably, because there has been a great impact of COVID-19 in terms of transmission of MDROs or multi-drug resistant organisms. And some factors that have led to this would be the high rates of admission and the lack of hospital beds. I remember especially during the surges of COVID-19, everybody or most of the patients wanted to be admitted. And if not, even if they didn't want to be admitted, those with comorbidities and elderly had to be admitted. And this led to shortage of hospital beds, shortage of staff, and shortage of PPE, especially in the beginning of COVID-19 pandemic. And the high acuity of patients with prolonged stays in overcrowded facilities, this is a good driver for transmission of infection, not only of COVID, but also of these multi-drug resistant organisms. With the higher acuity of patients in overcrowded places, not only in the wards, but also our emergency rooms, there was a high demand for mechanical ventilation, leading to higher rates of ventilator-associated pneumonia. And there was also, again, an increased use of broad-spectrum antibiotics. Now, all these led to increased hospital transmission of MDROs. Now, a fun fact or a sad fact, antimicrobial resistance is not just an existential threat. It is another global pandemic in itself, and it has been occurring for decades already. It's been present for decades already. And millions of antibiotic-resistant infections have led to more than 700,000 deaths per year. And this is something that we should be aware of. The pandemic is not just COVID. There are a lot more, and antimicrobial resistance is one of those. So therefore, the adherence to antimicrobial stewardship programs is very important because there is already data. As early as now, within a year, they have looked into the impact of AMAS programs in the midst of the pandemic, and they found that there was a significant reduction in the duration of antibiotic therapy and the length of hospital stays of patients in cases where antimicrobial stewardship programs were accepted and being implemented. So this is a good take-home message for everybody. Okay, so I think this is one of my last slides, and this would somehow glue the concepts together in terms of AMS and COVID-19. So antimicrobial stewardship in the midst of the pandemic can help us all clinicians in many factors. Number one, I've mentioned this and I've emphasized it, we can limit unnecessary antimicrobial usage in terms of antibiotic use, especially in mild to moderate cases wherein most of them do not need antibiotics at all. In terms of treatment compliance, wherein patients will be monitored on active therapy and the dosing will be guided also by AMS. The AMS would also always remind us to not only create, but follow the local treatment guidelines in terms of antibiotic and now antiviral use and prior authorization. As early as the triaging of patients and in the emergency rooms, AMS can be consulted and we can be guided in terms of the anti-infectives that we would need for our patients. All right, so now I go to my take-home messages. The first message would be the goals of AMS remain unchanged. I know we are looking for updates here, but actually AMS remains the same. We just have to be reminded of the principles of AMS as we relate them to treating viral infections. Antimicrobial resistance is still very much present and is a pandemic in itself. So we would want to contribute to combating antimicrobial resistance in our day-to-day lives as clinicians. The third message would be antibiotics may actually be deferred. We may not start antibiotics in COVID-19 patients. So here, COVID-19 should be inserted until strong indications of a bacterial infection are present. And lastly, in severe to critical COVID-19, empirical antibiotic therapy may be initiated if risk factors are present in your patient. However, they should be re-evaluated on a daily basis, on a regular basis, and should be stopped as soon as possible if the probability of bacterial co-infection is low. And with that, I thank you. I think that's my last slide. So thank you again for inviting me to the first virtual Tiger postgraduate course. Thank you.
You may now proceed to our industry-sponsored symposia. Please go to www.tiktok2021.com and click on the room you would like to join.